The last time we were together, we began our look at clinical psychology. We're continuing that look today with a focus on two specific anxiety related disorders: obsessive compulsive disorder and post traumatic stress disorder. As is true of anxiety in general, it's likely all of us have experienced some of the symptoms related to obsessive compulsive disorder. Maybe we were waiting to hear about something, and so we checked the time on a watch or our phones over and over and over again. Or maybe we've been so worried about falling ill that we wash our hands again and again and again. However, there's a difference between sometimes experiencing a few compulsive habits and having a diagnosed disorder. People with OCD struggle with what's called the obsessive compulsive cycle: repetitive obsessive thoughts that they try to stop with specific compulsive behaviors. For instance, comedian Howie Mandel is well known as a misophobe, also known as a germaphobe, someone who has a fear of contamination and germs. Of course, many people are germaphobes, and usually these are people who take what others would call extra precautions during times of illness. They might always carry extra tissues and hand sanitizer during flu season, for example, or they might avoid a party if they know that a friend who's recovering from a cold will be there. But for some misophobes, their fear develops into OCD. That's what happened to Mandel. His fear of contamination is such that he literally runs away from possible infection. He immediately showers if he thinks he has been touched by an infected person. His repetitive thoughts, his continuous fear of contamination, are somewhat mitigated by his compulsive behaviors: running away, needing to take a shower, things like that. Well, Mandel has obviously been able to mitigate his OCD somewhat. He appears in public, but won't shake hands unless wearing latex gloves. He shaves his head to avoid contaminants that might settle in his hair. He's built a tiny house on his property where he stays if anyone in his family becomes ill. So it is possible to live, and live well, with OCD. Footballer David Beckham has also been diagnosed with OCD. Unlike Mandel, Beckham's OCD is manifested as an obsession with even numbers, and specifically with pairs, and with organization. He has revealed in interviews that he organizes his clothes closet by color and type of clothing. His shoes are organized by color and height. Beckham's wife, Victoria, has said that the family has 3 refrigerators: one for prepared food, organized in rows and in pairs, one for salad, fruits and vegetables, organized by type, and one for beverages. She commented that if there were an odd number of cans in the fridge, David throws one out. Everything has to be in even numbers. Like Mandel, Beckham has obviously been able to deal with his OCD well enough to become a successful athlete and sports executive. But people can suffer from OCD that is so severe that their worlds literally shrink to the OCD cycle. Sometimes, OCD can even paralyze a person's ability to act. A person with hoarding disorder, for instance, is unable to throw anything away because they believe if they throw something away, a tragedy will occur and they will need whatever it is they threw away, and they won't have it. And so their collection grows, overtaking their home, and they sometimes literally become closed off from the world. Like OCD, both acute stress disorder and post-traumatic stress disorder are like generalized anxiety disorder, except that it often spikes with the suddenness of panic disorder. Acute stress disorder results from the experience of or witness of a traumatic event. Symptoms include flashback memories, nightmares, sleep disturbance, hypervigilance, and panic attacks. When these symptoms persist for more than a month or develop 6 or more months after the event or trauma, then an individual might be diagnosed with PTSD. Post-traumatic stress disorder was first diagnosed with veterans returning home from war. It was originally referred to as shell shock. But as our understanding of trauma and stress improves, the psychological community has come to understand that many types of events can be traumatic. PTSD diagnosis spiked after 9/11, for example. Individuals who are survivors of sexual assault or abuse are also often diagnosed with PTSD. PTSD can be difficult to treat because it manifests itself so differently, even in people who are traumatized by the very same event. In fact, the majority of people who experience traumatic events don't even develop PTSD, although they might be diagnosed with acute stress disorder immediately following the event. When someone living with PTSD experiences a trigger, some stimulus which brings their minds and bodies forcefully back into that traumatic event, their bodies react as they did in the original moment. Psychologists believe that their experience of the stimulus trigger bypasses normal cognitive processes and heads directly to the midbrain, which in many ways controls emotion. Often, this experience results in a panic attack. As a result, many of those diagnosed with PTSD might simply avoid individuals or activities that might be associated with possible triggers. For instance, veterans might avoid firework displays. Survivors of sexual assault might avoid watching movies or TV shows that include sexual content. Now, it's all very well and good to name disorders and to understand the symptoms of these disorders, but why do they exist in the first place? Well, your book reviews the two approaches to explaining anxiety disorders, the learning perspective and the biological perspective. The learning perspective holds that fear, the root of anxiety, is learned, maybe through conditioning or through observational learning. This view connects back to the concept of learned helplessness. Some psychologists believe that individuals retain the conditioned fear even after having forgotten the specific circumstance that created it. Conversely, the biological perspective holds that there are physiological and often evolutionary reasons for the human predisposition toward anxiety. These reasons include over or under production of neurotransmitters or family predisposition to certain conditions. The reality is, it's likely that the reason why any specific individual experiences anxiety disorders is a mix of biology and learning. In other words, this is yet another front in the nature versus nurture debate. For instance, with generalized anxiety disorder, it's possible that some individuals are simply hardwired to experience anxiety more frequently than others. Then again, it's also possible that this genetic predisposition is worsened by an environment that is unstable and stressful. Theories about the origins of panic disorder include David Barlow's triple vulnerability model, which combines genetic predisposition and learned helplessness, along with a physiological oversensitivity to stimuli. The catastrophic cognitive theory incorporates sensitivity to stimuli, which would be genetic, with an individual's tendency to catastrophize an event, so that a person's reaction to stimulus, let's say a heavily beating heart, becomes in their mind a precursor to heart attack, and then spirals into a certainty that they're about to die, which brings on the panic attack. Phobias are a great example of the mix of nature and nurture as origins of anxiety disorders. There are many instances when a child might be exposed to a parent, guardian, or peer's particular fears through classical or operant conditioning or through observational learning. For instance, a child might observe that their parent always mentions a fear that they'll fall in and die if they go swimming in a pool. Over time, that child begins to connect death to water and develops a fear of pools of water. Of course, some phobias, like a fear of snakes or of heights, might have roots in evolution. Many snakes are poisonous and can kill you. Until you learn which snakes are dangerous, isn't it safe to assume that all snakes are? At the moment, some researchers estimate that about 4 million Americans have OCD at some time in their life, making OCD more common than panic disorder or schizophrenia. While OCD is most commonly found and diagnosed in late adolescence or early childhood, it can affect small children. OCD does tend to run in families, which initially led some researchers to conclude that OCD may be a learned behavior. However, these same researchers found that, generation after generation, OCD obsessions and compulsions take different forms. Where a mother who has OCD may be a compulsive checker, her son might be a washer. Moreover, further research into OCD has shown that most people living with a disorder show an underproduction in norepinephrine and or in serotonin. In addition, and specifically when stuck in the OCD cycle, these individuals show dysfunction in their frontal lobe and caudate nucleus, meaning they are at times incapable of stopping the cycle of obsessive repetitive thought and compulsive action. Unlike with OCD, there doesn't seem to be a predisposition toward PTSD beyond a more general predisposition toward anxiety. A PTSD is always associated with a traumatic event, but since not everyone who experiences trauma develops PTSD, it is possible that PTSD is more common among individuals who have experienced multiple traumas, not necessarily all of the same type, or who have family histories of instability and stress which contribute to their generalized anxiety. As has been true of pretty much the entire course, it's safe to say that psychologists don't yet know what causes a disorder like anxiety, but over time, we've been able to identify symptoms of various anxiety and stress-related disorders, and in treating those symptoms, can often mediate and even nearly ameliorate the effect an anxiety disorder has on the day-to-day life of diagnosed individuals.